So I've given you a little flow chart here. Starts up at the top, and board certified sleep specialist is BCSS. And this is in the guidelines paper, which I suggest everyone read. I just sort of took a portion of it. So does the patient have a high pretest probability of moderate to severe OSA? And the answer is no. Well, if they need a sleep study, they probably need a PSG. If the answer is yes, then you say, does the patient have symptoms or signs of comorbid medical disorders that would make a PSG a better route? And the answer is yes, they do a PSG. If no, then you go to the next step. Does the patient have symptoms or signs of comorbid sleep disorders? Now, this doesn't mean that if you have some restless leg syndrome that you couldn't do a portable monitor. But on the other hand, if you have sleepwalking, that wouldn't be a good route. So if the answer is no, then you do a PM. Or, of course, there's always the alternative to do an in-lab PSG. There's certainly, and that's the standard. But then at that point, you could consider doing a portable monitor. Well, a little bit about how you should do these. And your other talks are going to talk a little bit more about the specific technology. It's recommended that at a minimum, portable monitors must record airflow, respiratory effort, and blood oxygenation. Now, this is could possibly change in the future, but certainly for a respiratory person, a pulmonologist, these is the core. We want to know whether they're having apneas, apopneas. We want to know whether if it's an apnea, whether it's central or obstructive, and of course, blood oxygenation is very important. It's also said that the type of biosensors used to monitor these parameters for in-lab PSG are the same ones recommended for use in PMs. In other words, they should have the same technology because those are the better validated technologies. The sensor to detect apnea is an oral nasal thermal sensor, and to detect hypopnea is a nasal pressure transducer. Now, I will tell you that a lot of portable monitors really only have one airflow detection device, and this could be a limitation. But the guidelines recommend both. An advantage is that if one fails, you have another one for a backup. Ideally, the identification of respiratory effort should be calibrated or uncalibrated inductance plethysmography. And again, this is what's recommended for PSG. Now, for portable monitoring, you could argue that maybe you could get by with other technologies to detect effort, but that's what's recommended. The sensor for detection of blood oxygen is a pulse oximetry with appropriate single averaging time and accommodation for motion artifact. And I will tell you, the single most problematic thing in a lot of our studies is getting the oximeter tip to stay on the probe to stay on the finger correctly. And but obviously the oxygenation is just very important. So again, airflow, respiratory effort, and oxygenation, and the type of sensors are the same as for PSG. And this next slide just summarizes those. And I'm sure you're familiar from having done full studies of using both nasal oral thermal devices and nasal pressure. Now here's an example of a type 3 portable monitor. And type 3 has airflow, effort, saturation, and either heart rate or EKG. And here you see the nasal pressure, the nasal oral airflow thermal device sensor, chest, abdomen, there were RIP. Snore was available on this device as well. Saturation, pulse, and body position. And as you can see, so this looks a lot like your regular PSG tracings. And so this certainly, this would be a nice device to try to determine if sleep apnea was present, because it gives you quite a lot of information, and actually about the same information you get from a PSG except for EEG and legs. Now I'm going to talk about a little bit more about monitoring for what methodology here to continue. Now the methodology includes not just the devices, but what happens after the data is acquired, or how are patients trained on putting the device on. So portable monitoring should be performed under the auspices of an AASM accredited comprehensive sleep program with policies and procedures for sensor application, scoring, and interpretation of portable monitoring. A quality performance improvement program for portable monitoring, including interscore reliability, must be in place to assure accuracy and reliability. And so this is very similar to the guidelines for PSG. The idea being that if you want a high-quality program, you must have procedures and policies and some way to check whether scoring is reliable and accurate. An experienced sleep technician or sleep technologist or appropriately trained healthcare practitioner must perform the application of portable monitoring sensors or directly educate the patient in the correct application of the sensors. So I'd like to pause and ask, how many of you are applying portable monitors? Okay. Well, you know the challenges. There's several ways of doing it. You can have the person, you could go to their homes, which is problematic. You could have them come to the center and actually put it on, completely put them on. Now, a lot of people are a little embarrassed to go home that way, but you could have them have a cover shirt. Or you can train the person. Now, there are devices where they simply mail that to the patient and have a little CD. And I think those are problematic except for the most simple devices. But certainly the standard is for a technologist or sleep technician to actually either educate the patient about how to put it on, and usually in our center we actually watch them put it on. And if they can't put it on, we put it on for them. A lot of times we give them a choice. And actually at our VA we have so many studies, we do it in classes. They all come in and sit around the table with their significant other, and we go over the application, and then they put it on. We could see how well they put it on. And if they have problems, we say, well, gee, we'll just be glad to wire you up here and you can wear it home. And so, but as you know, it's a challenge. Otherwise, you're going to get failed studies. Portable monitoring devices must allow for the display of raw data for manual scoring or editing of automated scoring by a trained and qualified sleep technician and technologist. So the technologist must look at the data, and if it needs to be edited, if you're going to use automated scoring, then the technologist should look at it and see if they agree. A lot of our studies are fine. They work out okay. But then another sizable portion, we have to hand score, sometimes because some of the sensors weren't optimal. But in any case, certainly the technologist needs to know that before he sends the report to the physician, that he believes that the scoring is accurate. I saw the other day of a study that came to me where every apnea was obstructive, and I looked at them and I kept rubbing my eyes and I was saying, where is the effort? And it turns out this person had Cheyne-Stokes breathing with lots of central apnea. So the technologist said, well, that must have gotten by me. And I said, well, it happens. So the idea is the more eyes looking at a study, the less chance there are of missing something. So as you know, the reimbursement for these studies isn't great. And so it's important when you choose a device that the automated scoring is pretty good. But again, the automated scoring won't be very good if the signals aren't good. So, evaluation of PM data must include review of the raw data by a board-certified sleep specialist or an individual who fulfills the eligibility criteria. And I think that this is just absolutely essential. You know, and this is where I think a lot of primary care physicians may have problems. They like the numbers and the interpretation, but do they have the skills at really looking at the raw data? And I think it's just very important that someone look at the raw data. And it doesn't, by the way, take that long because you can just really go through quickly, but it's so important to make sure that the sensors were applied right. In other words, the signals are adequate and that the scoring is correct. Scoring criteria should be consistent with current published AASM standards for scoring apnea and hypopnea. And actually, there's a number of task forces now relooking at all of these definitions with the light in light of the fact that portable monitoring may require some changes in these definitions. But in any case, at present, that's the recommendation. Due to the known rate of false negative PM test in laboratory polysomnography should be performed in cases where PM is technically inadequate or fails to establish the diagnosis of OSA in patients with a high pretest probability. As already mentioned, a person you thought must have sleep apnea comes in and the AHI is low. And so you have to ask yourself, well, is that a false negative? There's been times where when we ask patients, and we have them fill out a little log, actually a very extensive sleep questionnaire and log, and a lot of times in these studies it turns out they were so nervous they didn't sleep. So that's why it's a false negative. But if they have a moderate to severe probability of having sleep apnea and you have a negative study, then that means when you have a high clinical suspicion but a negative study, that means you have to either repeat it or to go to the next level of advanced technology, which in this case would be a PSG. So all these patients that have negative studies that have a high pretest probability should have a PSG to determine if they really don't have sleep apnea. A follow-up visit with a physician or other appropriately trained and supervised healthcare provider should be performed on all patients undergoing portable monitor to discuss the results of the test. Well, this is just good medical practice. In other words, it's amazing at those follow-up visits, sometimes certain factors come to light that weren't so apparent. You learn, for example, that someone usually drinks several ounces of bourbon before sleep and didn't do it that night because they were embarrassed. I don't know why, because the study was done at home. Maybe the person was fearful of having a positive study. In any case, you need to know it's another chance to look at the whole clinical picture to make sure you're doing the right thing. And we find it very useful to have the significant other there during these discussions. And you also then have to plan where to go, because the patient has to be involved with discussions of what to do about the results of the test. The task force that did these clinical monitoring guidelines concluded that unattended portable monitoring can be used within the parameters specified above in the patient's home. Then, that is, these devices can be used in the unattended mode. Previously, the practice parameters had always used the word attended portable monitoring. Usually attended portable monitoring of the type 3 devices were indicated. So this was the first Academy sponsored guidelines that said that the unattended monitors could be used. But again, that's with a lot of provisos that they're done, the studies are done correctly.